Hey, how you doing, everybody? My name is Dr. DJ Heusler. I am an ophthalmologist at the Animal Eye Institute, and so I thought we would start a new kind of series of content and videos going over different surgical cases, and so I thought we'd start with an easy one. This is a cataract case, yeah, let's get into it. So we're going to start with our limbal incision right here. I'd like to go with the limbus. It is creates less scarring to the eye, and so we've got. I don't like to go clear cornea if I can help it, and I also don't necessarily like to go into the conjunctiva because that can create more bleeding and more issues on that end. So we're going to go right in here at the limbus. And then I usually cut a little bit off the edges there as you see me sliding that back and forth. That opens up the incision just a bit. Go in with viscoelastic as well as epinephrine. Here we see now we're using a Vanna scissors. These are very small Vanna scissors in order to make the capsulotomy. And then you're going to see we're going to go right to left, medial and lateral, with these Vanna scissors in order to open up our capsulotomy. This significantly increases your efficiency in surgery. So we go medial and then we go lateral, and this will therefore make your capsulotomy about 50%, if you see, of your CCC, and so therefore it's much more efficient to do it this way than to do it with like a bent needle, or just make a tiny little incision and then start right off of your incision. So if you make that little bit of a smile incision there, that will help to improve your efficiency. So these are Utrata scissors, obviously, or Utrata forceps. And so watch right here. What we do here is to take the two ends of your forceps and put one blade above and then one blade below or under your capsule, and that is going to really help you to grab the capsule. I'm not a trypan blue user, and so this helps to grab the capsule, and you don't even necessarily have to see it. You just have to know where it is, and this will help you grab it. So instead of going side to side, flip your Utratas up and down. So I'm going to erase that little aspect there. Go back to our video. So lift straight up. If you lift up, you're not going to hit the cornea, and this will help to really widen that capsulorrhexis without necessarily having to do anything skillful yet. So that is going to increase your capsulotomy or capsulorrhexis essentially from here, which is where your scissor went, all the way up to about here, and then from about here all the way up around here. So if you look at it this way, you know, if you're looking at improving your efficiency, or even to just as you're starting out, this is a kind of a bit of a cheat, because then you really only have to know how to flip your capsule and just remove that last little section right there. So if you look at how much you've somewhat cheated with, is just by making your cuts and then lifting, you've got a good 80 to 85% of your capsulorrhexis already done, with the remaining 15 to 20% there left over in order to grab your capsule and then flip that over again. So again, I'm going to erase our markings here and go back and play our video. So then you really only have to grab your capsule just in order to flip it, and then just remove the last little bit right here. And so hopefully that will improve your efficiency and on one of the more difficult aspects of cataract surgery. Next is phaco. So I'm more of a one-handed phaco surgeon. I use two hands only when necessary. I know that other people start with two hands. I was trained more of a one-handed surgeon, and so therefore that's what I teach on. I think both are acceptable. Both can be utilized to train and for the right situation. So when we're looking here at phaco, we want to make sure that we're coming back as far as we can and then make efficient strokes forward. Okay, and then we want to work on one specific section, and we want to kind of move those both left and right and work on a whole section rather than going over here and then going over here. That's a really inefficient way to go about phacoing a lens. So again, I'm going to switch my eraser on, get rid of my markings here, go back to the video. So even here, they're not perfect. They don't, the phaco stroke length doesn't come back far enough. And so then I'm concentrating a little bit more up towards the edges. But you want to dig your groove right there on one section, and then you want to start moving into another section which has more of a chunkier or more volume to go after. So here I'm creating more of a bowl here and then gradually moving over. So you can tell that I started right in this section, and now I'm starting to move over here because there's more there. There's more from the up towards the anterior lens capsule, more volume, and so it gives you more of a safe space to work in. So rather than concentrate further down here near the posterior capsule, work more on what is given to you, which is the bigger chunks more towards the anterior lens capsule, and remove them in that fashion. So I erase my markings again. Here we go again. So now we're removing it. As we start to get more of a bowl here, we're going to switch over to our quad setting, our quadrant setting, and that increases volume quite a bit as well as increases flow. And so you can watch what we want to do here is we want to operate and pull our fragments into what I call the safe space, which is right here, and it's essentially right at the level of the anterior lens capsule. So you don't want to be working near the posterior lens capsule. You don't want to be working near the endothelium. You want to be right in this little safe, what I call the safe space, centrally, right near where your capsulorrhexis is. And I think that that's a safer way to prevent intraoperative complications. So I'm going to go back in here, erase, and hit play again. So what we want to do is go after what is there and what's easy for the taking. So this is a big chunk right here that is loose and wants to come out. So here you see it comes out, and now all of a sudden everything else starts to fold with it. So you don't have to do anything, just stay in the middle. So stay right there in the safe space. Watch things come to you. I'm essentially moving my foot up and down in between the 2 and 3 position on the foot pedal in order to improve efficiency, not have any pieces get stuck, and also to avoid pulling in any of the posterior lens capsule. So you can see I'm just gradually teasing pieces to come forward. We grab that piece right there, and then once you get those pieces out of the way, you just take what's easy, take what's in front of you. There's some loose pieces, grab those, get those out of there. Oh, there we go. And so it split that lens right there. Now you've got 2 separate pieces. You don't have to do anything about this. Stay right in the center, move your foot up and down on the pedal between spots 2 and 3, and stay right in the safe space and watch those pieces just gradually come into your phaco tip. So we watch these come in there. There we go. And now we were never really even near the posterior lens capsule, and we've got all of our pieces out. Now we're going to go in with our irrigation aspiration. This is a disposable irrigation aspiration handpiece. It does have a rubber tip here, which helps to kind of push on the posterior lens capsule if it were to come up near you. It therefore is very atraumatic, so they're kind of nice to use. And even though they are disposable, you can reuse them if you clean them appropriately. So here what we're doing is just gradually moving our IA handpiece out to the edge, grabbing a piece, coming into the safe space. And we can also see here, if we look, there is a little bit of an imperfection in the capsule, which we see right here. We're going to go back and fix that just in a little bit. So nothing to worry about, nothing to panic about. You can always go back in and fix that stuff. No big deal. So now we're just grabbing pieces, and then once you grab a few aspects there, I'm going to push the lens caps or push the pedal down a little bit further and then pull it into the safe space. So here we're just rotating the handpiece, staying right there at the level of the anterior lens capsule, staying away from the posterior lens capsule, and then just gradually pulling our pieces out of the cortex or out of the equator, and then working our way systematically around to get all this stuff out of there. So here we see a nice big sheet. We're pulling it towards the safe space again. And then the last little piece there is always the subincisional cortex, the pieces that are just underneath the incision. Those are always the more difficult ones, the harder ones to train. Just have to be a little bit more comfortable just coming out, sweeping, and then slow down, and then just rotating your fingers on the handpiece to grab that cortex and then rotate it out of that area. I don't really see any need for any J hooks or anything like that. I think those are kind of overkill and they clog very easily. So here we go. We're just going through and removing any other pieces that we see. We're going to reinflate with visco, and then we're going to do our capsular correction here, which is 0.7. Just going to grab that and just remove that, and we've got a nice complete capsulorrhexis. So here is our next aspect, which we're going to use our blade to just open the incision just a little bit, which will make room for the tip of the cartridge to go in. We're going to put that in there and then slowly inject it and watch that open up. Now, if you watch right here, you can see that our haptics to our IOL got stuck in the cartridge and got pulled in through the incision there. Not really that big of a deal. It's more of a pain, if anything. And so how we remedy that is, here's what I believe is the more correct way to load the lens, which is well, let me see if I can get that back going again. There we go. So we're first going to take our cartridge and we can put some visco down in it first. I don't necessarily think that's necessary, really. Some of my residents like to do that first. I don't feel it's necessary to lay a bead of visco in, but you certainly can if you're more comfortable with that. We're going to put our lens down in there with lens folding forceps and gradually kind of smush the lens down in there while we're folding up the wings to the cartridge. Then what we're going to do is put it in the injector. You can put a little bit of visco in either the back of the cartridge or the front. Either way is fine. But here's where this is important. Push it forward till you get a little bit of visco out. Then put your thumb right there. Okay, so put your thumb on the back. So we're going to put our thumb right here while pulling back right there. Okay, so after you do that, then what we're going to do is push forward a little bit more, and this unsticks the haptic. So this will prevent what we just saw with over here with the haptic getting stuck in the incision. So we can just use whatever instrument choice you like to use, a dialer or a chopper or anything, to center it and push it back in. We're using 9/0 Vicryl here as a limbal closure. Here's how I like to close my limbus. Go one pass through, come over to the other side, another pass through, then go back right next to where your initial one was. One pass through again. And this essentially acts like a bootlace, so you can pull both sides like a shoestring and it'll tighten it up. And then we go in and clean the remaining aspect of our visco out of the anterior chamber. And then we just tie off our Vicryl and close our ends, and then we're all done. So I hope you like this. I hope this helped a little bit. I hope to make a couple more videos like this to help people with cataract surgery and how I teach residents and improving efficiency and things along those lines. If there's anything that you want to see specifically, then feel free to let me know. Have a great day.